Thank you very much for joining us. Just a very brief welcome to the Empire Center's second Governor Hugh L. Carey Policy Forum on a topic that obviously interests all of us keenly. Just a little bit of housekeeping, and I'll give way to our main speaker and then our panel. Our format today is pretty simple and informal. Bill Hammond, our Health Policy Director, is going to begin by presenting on the subject of the title of our event, which is Medicaid Migraine, and a talk about the issue with Medicaid funding as it's developing now in the state budget. He will then join and introduce our distinguished panelists, and each of whom will give their point of view on this, and he'll join in that discussion, and then there will be time for questions from the audience. Another note for you, we are going to have a video of this event online uploaded, we think by tomorrow afternoon or at the latest Friday morning. If you go to our website, empirecenter.org, we'll send you a follow-up email with that, I believe, and you can pass that around if you find it interesting and worth sharing. We've had some inquiries on that already. And so other than that, I would ask, the stock warning, just a reminder, if you have your cell phone, please silence it. And with that, I'll introduce somebody who literally needs no introduction, and that is our Health Policy Director, Bill Hammond, who will begin with his presentation today. Bill?
Thank you and good morning. It's nice to see so many faces here, including our really excellent panelists. I'm looking forward to a good discussion. I have to say, okay, so this headline appeared in Newsday on Sunday. And I have to say, when I started working on this report, I really had no idea that this would be such a topical subject. I also happen to have listened to, maybe some of you heard about this interview that the governor gave to Alan Chartock yesterday. I listened to it, on the web. I think I may have been the only person who wasn't listening to hear him say the N-word. I wanted to hear what he had to say about Medicaid, which included the revelation that he does not fully understand the issue related to the delayed payments. So we're going to, hopefully at the end of this, we will understand it a little bit better. I guess I want to point to something in this story. It's reflected in the headline and also in the quote in the second paragraph, which says that the practice of pushing costs into the next fiscal year is simply managing the timing of Medicaid payments to ensure compliance with the global cap. And I guess I want to say right off the bat that this is by no means represents compliance with the global cap. It's a really interesting interpretation of the law, and it's not consistent with what the governor himself said when he first introduced it. This is from his very first, when he did a slideshow, when he did the budget presentation, February 1, 2011, he'd just taken office. He was facing a very large $10 billion projected gap in his budget, a lot of which was related to Medicaid, a lot of which was related to the fact that federal funding that the state had received for Medicaid under the stimulus after the Great Recession, that was going away. So that was partly kind of a unique circumstance. But he talked about how there were these automatic trend factors built into the Medicaid law, and that was driving a lot of spending. And so he said, we're going to set gross and Medicaid to a fair and objective standard. We're going to, it's going to help us close this year's deficit, but it's also going to help us prevent deficits in the future, and it's also going to constrain unsustainable spending. So the plan that he proposed, in which the legislature approved, had sort of four interlocking components. One was you would establish a rate at which you were going to allow the Medicaid budget to grow. Previously, you had these automatic trend factors that were kind of a floor for how much increase. This was going to be a ceiling on the overall budget. They linked it up to the 10-year rolling average of medical inflation, which is it's a benchmark that the Federal Bureau of Labor Statistics puts out. It's been running about 3 or 4% lately. Then you would bring in a bunch of stakeholders from the healthcare industry and some state officials and members of the legislature, and you would have a serious talk about how you were going to meet that cap. And you would try to find productive ways of saving money that would minimize the damage to the system and to the people receiving care. And to keep everybody honest, there was this transparency piece of it where you would track actual spending on a monthly basis, compare it to what projected spending was supposed to be if you were going to meet the cap, and you would report this out monthly. And then, kind of the fourth piece, which made the other three real, was this threat that you're empowering the executive branch if spending exceeds the cap in the middle of a fiscal year. You're empowering them to take pretty draconian action to unilaterally to cut fees and reimbursements across the board, or more or less across the board, in a way that would keep spending low. And that has never been invoked. It's an extraordinary level of authority that's never been invoked, but I would argue that the threat of it was necessary to make the rest of it work. You know, to get people on the Medicaid redesign team to make real compromises and accept real cost cutting. There were a couple of caveats that I should bring up. One is that it's called the global cap, but it didn't apply to all spending. It applied to the state share of spending, it's roughly 40% of the total. And in particular, it applied to Department of Health Medicaid spending. There will be a few acronyms today. I think of it as mainstream Medicaid. It's people who qualify for Medicaid primarily because of their income. What it doesn't include is the so-called mental hygiene, mental health, developmental disabilities, and substance abuse. That's not to say, well, I don't want to get into the weeds too much on that, but that's a relatively small part of Medicaid enrollment and Medicaid spending. And in fact, although the law doesn't require them to do this, the Cuomo administration has been paying some of mental hygiene under the cap for reasons I don't fully understand, and the amount seems to change from year to year. Another big piece that it doesn't cover is federal aid, and so if federal aid grows, the state didn't have to worry about spending that extra money. That was not going to affect the cap, and in fact, this happened to be an era when federal aid was growing quite rapidly because of the Affordable Care Act. And then they decided to exempt certain defined costs from the cap calculation. At first, it was a very small amount. Administrative costs, the takeover of local administrative costs was exempted. These exemptions or loopholes got bigger, and there were more of them, and they got costlier over time. So there was this plan was greeted with a certain amount of skepticism in Albany because you were talking about a really fundamental change in how Medicaid the Medicaid budget was put together, and also you were talking about a dramatic slowdown in the spending patterns. The legislature had in the past, in occasions of real fiscal crisis, had controlled Medicaid costs because they really had no choice. But you were talking about an ongoing restraint on Medicaid, and you know, as the governor correctly says, we had a history of double-digit increases, and so the idea that you were going to slow it down to 3 or 4% a year, it was a steep hill to climb. But also, you were talking about moving a lot of the decision-making out of the legislature into this Medicaid redesign team, which was essentially an executive branch operation. Which had certain virtues. It allowed for longer-term planning. It drained a lot of the political heat out of things. The ad wars that some of us who've been around for a while remember, they pretty much stopped. And also, those fights over Medicaid were one reason that the budget was late so often. And that meant that the health department couldn't really tackle the reforms that it got. It would fight really hard. It would get limited reforms, a fraction of what it wanted. They would be given permission for those reforms late in the fiscal year. And by the time they started implementing them, they'd be back in the budget battle again. And sometimes the legislature would roll back what they had done the previous year. So that was not a good system, and this promised to be very different. I know there's a lot of skepticism about even after it was in operation and it seemed to be working, there was a lot of skepticism that they were fudging the numbers, and I think with good reason. But the numbers, at least for the first few years, were pretty impressive, I think. Notice that the blue bars are the spending. They were basically flat. This is total spending, so it includes stuff that the cap didn't cover. And they were basically flat for 4 years, and then there was kind of an uptick in the fifth year. But that reflects a huge run-up in enrollment with Obamacare. So over 1 million people joined the rolls in 1 year. And so if you kind of calculate the growth in spending over those 5 years, it was about 17%. It was in spitting distance of medical inflation. Enrollment was up 31%. So this is a sign of a system that's working relatively well. But over the next 5 years, the pattern changed very dramatically. Now it kind of flipped. Now it was enrollment that was pretty well flat, and it was spending that was going up at a good clip. And this resulted in kind of a mirror image on the per recipient spending. So when the governor, we have a long history of spending a lot compared to other states. This is probably hard to read, so I'll read some of the numbers. The red bar is New York's spending per recipient, and the blue bar is the national average. When the governor took office, we were over 11,000 per recipient, and the national average was just over 7, so there was a really big gap there. After a few years of restraint on New York's Medicaid spending, we got that number down to 10, so it was still considerably higher than the national average, but the gap was closing. That's partly a function of the fact that the new enrollees, the people who are flooding in, were sort of generally healthier than the previous population. But still, this is like a good trend for a state that has had trouble controlling Medicaid costs. And it wasn't accompanied with any, like the benefits were, if anything, were better. Certainly they were covering more people. I'm sure people could point to things that in the provider community could point to financial restraints, but it wasn't like our Medicaid system was functioning as well as it had been, more or less. So more recently, though, under the spending growth of the next 5 years, our per recipient spending really kind of went through the roof. It erased the progress of the previous years and reached a new high of $12,000. And there's no sign that it's slowing down. So why this changed? The global cap was in place throughout that period. What changed? Well, for one thing, it was kind of a structural issue with the cap. It didn't have an adjustment for enrollment. So if enrollment was going up, it was always going to be kind of tight. And then when enrollment flattened off, it got a lot looser. And in fact, you could argue that at that point, it starts being a license to spend rather than a constraint, because you have the 3 or 4% growth, and programs often will grow to fill the available budget space, and so that's what happened. Also, the first few years, there was relatively low-hanging fruit in terms of cost cutting to be done. And some of those reforms worked really well and saved a lot of money. But then other things they tried to do that were more complicated and took more years either fell short or backfired. So that was one of the things that changed. Another was self-inflicted. They added loopholes. When they froze the local share, so in New York State, kind of uniquely, we require counties in New York City to pay a substantial share of Medicaid costs. That used to be pegged to the total cost. Now, under Pataki, it was what was it? Capped, and then after 2012, it was frozen, held absolutely flat. That created extra costs to the state. They exempted that from the global cap. And then maybe the biggest one of all was when they did the minimum wage hike, which was a big one. It went from, was it $9 to $15? They decided, they recognized that was going to create costs for providers, which was going to create costs for Medicaid, and they decided to just carve that out completely from consideration in the cap. And I have to say that was a kind of a fateful decision, because you're like when you carve out the local share, you're talking about moving money from one level of government to another. You're not talking about growth in total cost. The minimum wage hike resulted in growth in total cost, and it's labor costs, and labor costs are absolutely the dominant thing in healthcare. And so if you're not reflecting your labor costs in your global cap, you're not really capping anything of significance. Another big issue, which we'll talk about later, is a surge, an ongoing surge in long-term care enrollment and spending. And then the final straw this past year was there were certain issues with enforcement, and this past year was kind of a moment of truth for enforcing the global cap, and it was not enforced. So what happened in 2019? This shows the portion of Medicaid spending that's theoretically subject to the global cap. This is DOH Medicaid spending. The blue part of it is the part where they've said it can't grow faster than medical inflation, and the red part of it is the loopholes. And they started quite small, and they got bigger and bigger. Last year, they reached the level of almost $2 billion, close to 10% of the part of the Medicaid budget that was supposed to be constrained by the global cap. And I guess when you get to the point where your loopholes are 10% of your total, the cap is becoming less and less relevant. But here's the thing, when they got to the end of the fiscal year, their actual spending was $1.7 billion higher than that. So and by the way, that didn't just materialize in March. That was accumulating gradually. It first started kind of rearing its head in the summer and fall. And that was the moment when, according to the global cap statute, the Department of Health Commissioner and the Budget Director shall create a Medicaid savings plan. That's what the law says. They shall get together and figure out a way to cut costs and keep things under the cap. Another thing that stopped happening was these monthly reports. I mean, they had periodically missed monthly reports in the past. There's probably a lot of work to do. They stopped altogether in November of last year. And so when the governor's budget came out and all through negotiations, there was no official record of where we stood with respect to the cap. So what they decided to do, instead of cutting spending, was this fateful decision to postpone $1.7 billion worth of payments from the end of March to the beginning of April. That moved the expense for bookkeeping purposes from the previous fiscal year to the current fiscal year. But none of this was reflected in the budget negotiations. It wasn't reflected in the financial plan that the legislature passed. It wasn't disclosed to the public until, I believe, May. And it didn't become widely known until even later than that. So I would argue that was just a plain violation of the global cap law, that it was not being implemented. I mean, there's no penal clause in this is like, but it was not the way this was supposed to work. This is kind of a scorecard. Medical inflation from 16 to 19 was 7%. Enrollment was flat. Every index of spending, whether you look at just state share, total share, federal aid per recipient, it was all up 2 or 3 or 4 times the rate of inflation. So it's hard to argue that the global cap is having really any constraining effect. I mean, I think it did seem to be working for those 5 years. And as I talked about, it changed the dynamic of the planning process. And so I think it seemed like there was some value to it. It allowed for long-term planning. It allowed for, people could think about year 3 and 4 down the road because, they had a reasonable confidence about what their budget was going to look like. And the political dynamic was much less acrimonious. But at this point, it doesn't seem like it's really preventing us from preventing high rates of spending growth. I wanted to go back to the long-term care thing. This is overall enrollment was flat, but managed long-term care enrollment is anything but flat. It has quintupled since 2012. Now, some of that is a shift from fee-for-service into long-term care, which is exactly what state officials wanted. But I think towards the end of it, it seemed to get away from them, and they're seeing unanticipated levels of growth, and it's continuing to go up. That last bar is June. And a big piece of this is what's called personal care. This is non-medical services provided in the homes of people who are disabled. It's a really important service for a lot of people. New York it's an optional benefit under Medicaid. Most states who do have it, there's 33 states who have it, and most of them treat it as kind of a limited program with caps on the number of people who can use it and caps on the spending and caps on the hours of service. New York treats it as an entitlement with no formal limits. So our spending, when the governor took office, was $3.2 billion, which was 23% of the national total. So we, in one state, was spending almost a quarter of the entire national spending on Medicaid spending on personal care. This is what happened as of 2016. It had grown dramatically, and it now accounts for 40% of total spending on personal care by Medicaid. I hope we're going to go into this piece of it more during our panel discussion. That's what I wanted to say about the global cap. We're going to take a few-minute break before we start our panel. And there's more details, if you're really that curious. There's more details about this in my report, which is available outside. And thank you all for listening. So we're now going to move on to the second phase of our forum, which is a panel discussion with some really excellent presenters. I'm going to introduce them one at a time, and they're going to have a chance to speak, and then we'll have a back and forth and eventually open it to questions from the audience. Our first speaker is Rose Duhan of the Community Healthcare Association of New York State. This organization represents 68 federally qualified health centers across the state. Before joining Chicanes, is that how you pronounce it, Chicanes?
Yes.
In 2017, she was Assistant Secretary for Health and Assistant Secretary for Mental Health in the Office of Governor Andrew Cuomo. She previously worked for the Albany County Department of Management and Budget, where she designed and implemented long-term care system reforms. She has also held statewide policy development and advocacy positions with the New York Health Plan Association and the Healthcare Association of New York State, so she's got broad experience of different parts of the healthcare system. Rose.
Oh, go ahead. Okay. Okay, good morning. I am so excited to be here. This is my favorite thing. I could sit here all day and talk about Medicaid and the history of Medicaid. I told Laura earlier that I spent my weekend going back and reading everything I could. I read the Berger Commission report because I was so excited. So I will say, however, there are some people in this room who can speak a lot better and more first-person account about much of that history and much of the development of how we got to where we are in the Medicaid program. So I will hold some of that for the Q&A, and I think it may be comment more than questions where folks can contribute their experience that they've had in this area, because we have a lot of wisdom in this room. So I am privileged to be able to speak a little bit. I've got some good-natured ribbing from my panelists because I do have 2 slides. So I'll just start there. My first slide. So many people in this room, I think, have seen this slide. Is there anybody who has not seen this slide? This is a very popular, this is a very popular comparison of what we spend in the U.S. On social care and health care compared to other countries. Overall, the overall spend is actually not that different. But arguably we have much worse outcomes, and I think you can see from this slide that how we spend money in the U.S. is a different distribution. And again, I think the kind of the story that's told with this slide is that the health outcomes for the spend that we get are worse compared to our other developed countries. So this got me to thinking, we spend a lot of money in New York State on Medicaid. But are we spending it on the right things? So with the help of the very talented and brilliant Marie Manjon, put together the next slide that looks at how we spend money in New York State budget. And you can see that the Medicaid spend represents about 41% of the budget. Although I guess that's not really true because it's not, okay, ignore the the percentages, but you can see that what we spend on Medicaid compared to on the my left, your right, is the combined spend of all of human services and the non-Medicaid portion of the Department of Health. So that's all of our public health spending. That's Office of OTDA, OCFS, Housing Community Renewal. So everything else that really drives people's health. I think it's very funny that in this day and age, all of a sudden Medicaid has discovered the social determinants of health. 80, 90% of what really impacts people's health is not your medical care. I think that's also a really important piece to remember. And so the fact that Medicaid has discovered social determinants of health, to me, seems very backwards. You young people in the room may not remember that actually Medicaid used to be part of the Department of Social Services. Medicaid was a health care benefit to ensure that people could have economic security, to ensure that people could live the lives that they wanted to live. It was only when Medicaid kind of got too big for its britches and thought, let's have medical care that's like, everybody should have a equal kind of access to medical care. Medicaid needed to be its own thing and spun out of DSS. So, again, there's plenty of other people who can argue whether that was a good decision or not, but I think they lost some of that perspective of what really drives people's health conditions. So now here we are, and we have DSRIP, and DSRIP is saying, we have these social determinants of health. Let's think about addressing those. Well, maybe we should think about actually investing in the existing social services infrastructure, as kind of anemic as it is, if we really want to improve outcomes. And the more that we spend on medical care, we're not necessarily going to get better health. We're going to, and if we really invest in the things that are going to change the trajectory over time, those are really the things that influence the social factors that really influence people's care. Access to food, access to housing, racism, all the kinds of disparities that we have. Those are what really, I think, are driving the healthcare costs. Unfortunately, those are things that can't be changed in a one-year budget cycle. Those are things that really need an investment over the long term, which is really hard for New York State to do. As Bill talked about, they can't even sort of manage the huge budget that they have, and to try and turn that around really is going to take a long time. It's not something that can be fixed immediately. And the kinds of changes that are needed to really change the healthcare trajectory spend are things that really happen over a generation. My good friend John Rodat, who was here, observed yesterday that when he started on the board of the local dialysis, the Rubin Center, about 15 years ago, there were about 4 or 5 dialysis organizations that provide dialysis in the Capital District. Last spring, there were 18. That could be. I don't think it's all because of meeting a need that was unmet. I think that there's been a huge increase in the kinds of in drivers that lead to need for dialysis, significantly diabetes, which really is a result of diet, exercise, other kinds of life factors. So that would be my kind of radical observation for the day. And I
Thank
will
you.
turn it over. I would like to say more, but
So our next speaker is Jim Lydell. He is a partner of Manat, Phelps & Phillips, where he leads the Albany office. He's a member of Manat Health. He represents a broad array of clients, including 3 coalitions of not-for-profit and government program-focused managed care organizations. He's a former chair of the health law section of the New York State Bar Association, and he was assistant counsel for Health and Human Services under Governor Cuomo, meaning Mario Cuomo, from 1983 to 1986. Jim Lydell.
Thank you very much. First of all, hats off to Bill and the Empire Center for constantly putting spotlights on issues that may not generally be discussed as much as they should be. And I will confess that while I don't always agree with his commentary and analysis, it is the first thing I read when I find it in my inbox. So a couple of observations first at a sort of high level. I don't think it should surprise any of us that Medicaid continues to be a program that requires more cost discipline. It's had that characteristic, I think, for as long as it's existed in New York. Bill referenced my work with the first Cuomo administration. 37 years ago, the first meeting I went to in that office was about Medicaid cost containment. This was when John Rodat was still working for the Assembly Health Committee. That shows how long ago it was. Yes. And every year, I suspect, from about 1966 to the present, there are meetings like that being held all the time. It is a program that has been difficult to restrain and continues to be so. We are a compassionate state. We have a very difficult time restricting, expanding eligibility, benefits, services to people who are in need, and that's a good thing. At the same time, we're also a state that has very strong special interests who also don't like to be told no, and that has put us in the position that we're in today. The issue goes way beyond Medicaid, and it sort of builds on the slides that we tried to prohibit Rose from using. But just in the last couple of weeks, a report was issued that said that about 1/5 of our spending on healthcare nationally is a complete waste of money. And what's even more disturbing about it is that while we have a pretty good idea about how to reduce that total, we can only reduce about 25% of it. 75% of that waste we don't even know what to do about. So we have a huge problem as a nation in containing or improving the way in which we spend on healthcare. And New York's Medicaid problems are just, I think, reflect that. Third, I'd say that while I think the cap was a really good idea to impose some discipline on the growth in the Medicaid program, and the governor should also be congratulated for putting really unprecedented fiscal restraint on the rest of state government spending at the same time. The global cap doesn't actually cut costs, it only counts them. It would be like trying to solve global warming by buying a really good thermometer. All we're able to do by virtue of the global cap is to know where we are and where we stand, and that's important. I don't mean to suggest it isn't, and we do have some draconian, so far not used, but potential drastic steps that can be taken, not to really reduce the underlying costs of the Medicaid program, but to cut rates that will underpay providers or plans for services that they're required to provide. The strategies to really reduce costs are far more difficult, require far more creative thinking, far more political courage, and far more discipline than just keeping track. So at the source of these problems, and Bill's comments focused on this, long-term care seems to be a central player. That's, again, not surprising. From the get-go, the big driver of costs within the Medicaid program, and the one most difficult to contain, has been on the long-term care side. Medicaid is, at the end of the day, a payer of first resort for long-term care services. As you all in this room probably know, Medicare plays no role whatsoever for all intents and purposes, virtually not present at all. And so long-term care is an expensive proposition. Part of the cause of this expenditure is demographic. We have an aging population that we've been warning ourselves about for a while, and John and my presence here demonstrate it. But we also are not only an aging population, but we're an aging population that does so and ages now with less support from family and community resources than it probably used to, and than it does in other parts of the world. So I have a bias in this. We represent, as Bill mentioned, some not-for-profit provider-based health plans. But I don't believe the managed long-term care program is the cause of the problem. For the last couple of decades, the program that I refer to as the Kissinger program, for the last, he's now denying it. For the last couple of decades after its inception, it was widely viewed, including by independent analyses by all sorts of groups, as a key part of the solution. Growth in expenditures was substantially slowed, access to care was improved, care was coordinated, and significant dollars were saved. The meeting that I referenced 37 years ago in the governor's office was, in fact, about how to move the Medicaid program in a managed care direction, a strategy that has worked both on the mainstream side and on the managed long-term care side, and in fact has generated the surpluses and bonus payments known now as DSRIP or other things that we've been able to invest in other initiatives. It is true that managed long-term care enrollment has spiked in the last couple of years, but it's not, it has not been an across-the-board phenomenon. Enrollment in managed long-term care in 2015 was about 127,000 people. By last month, it's about 244,000. This growth, most of the legacy managed long-term care plans sponsored by organizations like Visiting Nurse Service, Metro Jewish Health System, entities that have been around in the long-term care space for a century or more, have not grown all that much. A couple of plans that were singularly committed to caring for people with very severe disabilities no longer even exist, since the rates of payment for those plans did not cover the high cost of the services that they were providing. A couple of plans have grown exponentially, mostly for-profit plans that have been late entrants to the field and saw an opportunity to grow the program and have seized it. One of them had just a couple of thousand enrollees 5 years ago and now has over 36,000 and is the largest plan in the state. What drove it, in part, has been the consumer-directed personal assistance program, which in a way is a sort of tragic story of Medicaid in one program, and that is that it is a wonderful, beautifully conceived program to provide autonomy for people with disabilities to hire someone who they would supervise to provide their services. And in some parts of the state where there isn't enough home care service, it's absolutely essential. But the program and the fiscal intermediaries who supervise it were not subject to sufficient oversight. New York is unique, I think, with a creative category of Medicaid entrepreneurs who, whenever there's a program that can be exploited, seize it. And and that is what has occurred, and it's helped drive managed long-term care enrollment. There are proposals underway to try to address the problem that have had some difficulty in the implementation, to say the least, including now an adverse court decision. But while we have quarreled with the way in which the department has tried to address the issues in this program, I think the effort to rein it in is in the right place. At the same time, trying to preserve the program to meet its real purpose. So anyway, I haven't seen my sign that tells me. Oh, I have 2 minutes. Okay. So
You're on the clock.
okay. My biggest concern about all this is that somehow between now and April 1st, the state's going to decide to try to solve what is really a multi-year problem in a few months. And whenever that occurs, lots of people get hurt, including both providers and plans. And I hope that's not the way we go. This has been a long, simmering issue. These deferrals have taken place in the past. I should point out that the $1.7 billion in deferral this year was very well known to some category of New Yorkers, namely the managed care plans whose payment was delayed into this fiscal year. But I'll leave it there. Thank you.
Thank you, Jim. Our next speaker, Lara Castle, is coordinator of Medicaid Matters New York. It's a coalition of more than 100 organizations representing the interests of Medicaid consumers. She was a member of the Medicaid redesign team and sits today on the DSRIP, and I'm not going to try to say what DSRIP stands for, Project Approval and Oversight Panel. Prior to joining Medicaid Matters, she served on the legislative staff of Assembly Health Committee Chair and living legend Richard Gottfried. Please welcome Lara Castle.
Thank you very much. I'm really pleased to be here today, and I appreciate the opportunity. I'm especially pleased to see so many friends and colleagues in the audience. For those of you who may not be familiar with Medicaid Matters, as Bill said, we are a statewide coalition representing the interests of New Yorkers who are served by New York's Medicaid program. As you might imagine, our work is significant in that we come at this from the perspective of wanting to be an equal partner when it comes to, or a fair partner when it comes to Medicaid policy and budget making. So there are lots of different interests in Albany when it comes to Medicaid, and our mission is to bring consumer interests to the table when it comes to Medicaid policy making. We have over 100 organizations in our membership. We have dozens of individuals and advocates, including consumers themselves. Our membership is made up of community-based providers, statewide associations, community-based organizations, and advocacy and policy groups. Many of our members are represented in the room today. And again, our mission is to bring issues of importance and interest to consumers to the table. In thinking about the theme today and Bill's report, I'd like to start from the standpoint of what Medicaid is and what it was intended for. Medicaid is an insurance coverage program. It is insurance coverage for low-income people and people with disabilities. When you start from that standpoint, and bring that lens to policy making and budget making and looking at the global cap in particular, it's perhaps a very different perspective. The role of Medicaid Matters is to insist that all of this be looked at through that lens. And so that's sort of the starting place that I bring to the table. All of this, the advocating and bringing consumer interest to the table in the context of the global cap has been challenging. It takes very sophisticated fiscal analysis to understand Medicaid financing, where the money comes from, how it's spent, all of that, et cetera. And when we have come to the table with ideas for investments or perhaps defending changes that we think may not be a good idea, we are typically met with, but we have a global cap. And, you know, as Rose and Jim both pointed out, the nature of, an additional factor, of course, is that the nature of our budget making is being on a 1 or 2 year cycle makes it difficult to project return on investment beyond just our typical cycle. And sometimes we do bring issues to the table or ideas to the table that are a longer range investment with return in out years. You know, one of the other challenging things about operating in this environment is that, as Bill pointed out, there are exceptions to the global cap rules. And it's been difficult to understand what the exceptions, where the exceptions come from as far as, you know, are there rules, so to speak, around what the exceptions are going to be. And going back to the fundamental reasons that I just mentioned about why we have Medicaid, why Medicaid exists and what it was intended for, you know, from our standpoint as Medicaid consumer advocates, we would argue that exceptions to the Medicaid global cap should be dealt with in the same way that we encourage budget making and policy making, which is to say, who benefits? Do Medicaid consumers benefit from exceptions to the global cap? And so that's sort of, again, the lens that we would apply to that sort of thinking and that sort of advocacy. Specifically on the report, Bill took us down an interesting walk down MRT memory lane in a few paragraphs. And one line in particular, which was pulled out as a pop-out, the redesign team provided a calmer, more collaborative venue to hash out the complexities of Medicaid reform. That, I think, is a very generous statement. Having lived through that experience, I will say one of its biggest flaws was it was not representative. So should we go down the path of, you know, a reinvigorated MRT process, we as Medicaid consumer advocates will urge that the process be more representative, and that I or someone else not carry the mantle of all of Medicaid consumer advocacy. And in that time, it was the original Medicaid redesign team met in 2011 for a short time. There was then a process after that with a new MRT that had some new members and thankfully one additional Medicaid consumer advocate. And then there were a series of work groups. And it was a more inclusive process. As the work groups met and developed ideas, it was definitely more inclusive and more expansive as far as looking at longer range savings and looking at longer range goals. But in that very short initial time frame, it was a very challenging time to try to figure out exactly how that was all going to play out in the context of the 2011-2012 budget. Also regarding the report, I'd like to point to a mention of the commissioners, what some of us refer to as the superpowers, and quoted from the report, it gave industry officials an incentive to collaborate on finding savings. And that's a really interesting thing to point to, because what that means is that by design, the industry amongst itself, amongst the association, the statewide associations, had an incentive to find solutions and find savings amongst themselves without going outside, without a need to go outside to look at perhaps other stakeholders in the field, including consumers and consumer advocates, and perhaps including community-based organizations and other sectors to help come up with some solutions. So by design, by default, the threat of across-the-board cuts gave the industry an incentive that perhaps could have been better. And then lastly, pointing to the part of the report that talks about, why this has happened and thinking about potential solutions. One of the things that Bill includes is, thank you, provider subsidies. Quote, a substantial amount that Medicaid spends on subsidies for hospitals, often with little connection to patient care, and that Medicaid money should be reserved for providing care to those who need it, not needlessly subsidizing wealthy hospitals or propping open institutions that are no longer financially viable. This is an issue that Medicaid Matters has worked on for a number of years, particularly when it comes to our goal and our principle around advocating for public dollars being spent in a transparent and accountable way. We would agree that it's important to make sure that going back to the lens, the consumer lens, it's important to make sure that any spending be done with an eye toward, are the funds connected to actually benefiting people? And we may, thinking about that lens, we may not all agree on the solutions, particularly if you apply the lens, but from my standpoint, it's important to remember why Medicaid exists and what it's intended for.
Thank you, Laura. And thank you for reading my report so closely. I probably should have showed it to you before I published it. Finally, and I have to give a special thank you to Harold because, as some of you may know, we had someone else, Kathy Preston was intended to be on the panel, and she had a last-minute family emergency, and Harold miraculously agreed to sit in, so that we're very lucky to have him. Harold is managing shareholder of Greenberg Trauerig's Albany office.
Yes.
He co-chairs the government law and policy practice with a focus on government affairs and healthcare matters. He was a trial attorney with U.S. Department of Justice from 1984 to 1986. I didn't know that about him. And then he was assistant counsel to the governor. Again, we're talking about Governor Mario Cuomo, with responsibility for transportation, education, veterans affairs, and freedom of information matters. I first got to know him when he was arguing a case before the Supreme Court. I believe it had to do with health care. This is something he's done a few times.
Once.
It's only the once? Okay.
Only once.
Welcome, Harold Island.
So thank you. Those of you who know Kathy know that I will probably be slightly less provocative than she would have been, but I will do my best to convey both her thinking and my own thinking. And I do want to say at the outset that I also agree that the cap has been a useful tool. If nothing else, it has added predictability into budgeting, and predictability, whether it's up or down, is a very useful factor in figuring out healthcare spending more generally. So just as an overview, I think it's been a very useful and intermittently effective tool. I will say, as to the Medicaid migraine, that I think the explanations of why we are here today are not all that complicated. There are several drivers of Medicaid costs. I'm going to walk through them, but they're not hidden. For the most part, they are in plain sight. And again, Bill, kudos to you because you ferret many of them out and shed some light on them. But essentially, when you think about the Medicaid financing, you've got three pieces to it. You have enrollment, you have healthcare costs, and you have what Bill called loopholes, but I will call special programs. Enrollment, we've seen data. It's a good story. We want people covered. The mainstream increases, the mainstream managed care program increases have been important for coverage expansion, and a lot of that relates to things that happen under the ACA and how we manage things. MLTC and long-term care enrollment presents some other challenges that Jim has touched on, but much of that, again, as we know, is demographic. So I don't think that increases in enrollment is something that we should be wringing our hands on. And to Laura's point, if your focus is on consumers, enrollment increases is probably a good thing. I do want to focus on healthcare costs because I think that's the area that is driving increases and that we do need to focus on. And again, there are, in my view, three pieces of that. One is new benefits. I mean, not a surprise that when you add benefits to what Medicaid covers, whether it's fee-for-service or managed care, your costs will go up. Those benefits may be important to add. I'm not putting a value judgment on it, but when you look back over the history of the cap, probably every single year we have had increases in one way or another of benefits that get added to Medicaid coverage. So again, no surprise the costs go up. The second component is utilization. So what's our story on utilization? And there I think we have a very successful outcome on what's happened. When you look at the early years, and even today, what you see is that utilization is, fairly stable. It's not spiking. Even in long-term care, while we've seen a lot of growth in enrollment, when you look at the personal care program and the hours per person, they are relatively flat. Hours are flat. So that, again, there's more to that. I don't want to oversimplify it, but I would simply say that I do think that the migration of people to care management for all and to managed care has been successful because the utilization of services is not what is largely causing the migraine. Now we get to unit costs. So unit costs are what does the state or what do health plans pay providers for services? And that's not such a rosy picture here. So first, I'm going to talk about three components of that. First is minimum wage, which everyone has touched on. Now, I want to add a little different perspective. And the governor mentioned it yesterday, so it's out there. When the minimum wage increase was pushed through, that was supposed to be outside of the global cap. That was the deal. But that's not exactly what has happened. Some of the minimum wage costs have been pulled into the cap. There are reasons for that. I'm, again, not putting a value judgment on it, but when you look at how managed care premiums are constructed, you can go back and you can see that some of minimum wage was pulled into, let me say it differently. Some of the wage increases that were occurring, most of which were attributable to minimum wage, were pulled inside the global cap, even though the deal at the outset was that they would be outside the global cap. The second, again, no surprise, pharmacy. If you look back over the life of the global cap, you will see that pharmacy costs have been increasing, again, many times for good reasons, sometimes maybe for more questionable reasons. When we saw the new Hep C drugs come out, which, again, very successful clinically, but no surprise that at an $84,000 per treatment cycle, with lots of people with Hep C, you are going to see your pharmacy costs go up. And that data is there. People can dig it out and find it, and you can see that that is a cost driver. The good news on unit costs is that physician costs are relatively flat, and especially primary care. So kudos to Rose. I know she'll be glad to hear it, but
No, that's not a good thing.
well,
One man's cost is another man's salary.
it's a good thing in the fact that it's not causing a migraine, Rose, okay?
It's causing her a migraine.
Well, but the message in this is obviously, when I get to my last point, that we do need more investment in primary care. But what we've seen for what's causing the problem, it's not physician services generally, okay? Those have stayed. as a relatively flat percentage of what the managed care premium is. And then we have hospital costs. So hospital costs, and I don't want that limited to inpatient because it's outpatient too, are increasing. There was a really good study just last week, I think, on healthcare costs that showed what all the data shows. Hospital utilization is coming down, but unit costs are going up. So again, no mystery. Healthcare costs are going up. And if healthcare costs are going up, it's going to put a lot of pressure on the global cap, and that's what we're seeing. We do have, so let me go to my third piece for a moment, and then I want to wrap up with one other observation. So there's a lot of money going to special programs, okay? Like billions of dollars that are in different pools. Most of them are being paid out under Medicaid. No surprise why, because we like to draw down federal matches on things when we can. Again, some of those programs may be very helpful, others probably not so helpful, but maybe most importantly, we have programs that go back years. Even if they started with a good purpose, now is the time, given a crisis, to look at them again. Say, are they still doing what they were intended to do? They all have nice names, but not all of them are still really needed to do the costs. It's to do the function that they were set out. It's just in New York, we have a hard time ever taking anything away. So I want to make one last quick observation about the global cap, and that is, and this is a good topic for you, Bill, to think about the interplay between the global cap and the general fund. Because for the budget geeks in the room, there is a significant amount of creativity that goes on allocating costs to the global cap or to the general fund. It's all ultimately state spending, right? But there have been years where the general fund has offloaded costs onto the global cap part of the budget. There are years when it sometimes goes the other way. Bill, you mentioned OMH costs and why are they in the cap and why are they outside the cap? And there are some good reasons, and in part, as OMH costs are being brought into managed care, they tend to go into the global cap, and that makes sense. But minimum wage is a good example, but not the only example of costs that maybe start out as general fund but end up in the global cap. Sometimes things go the other way, but you can't look at the global cap in isolation without going back and looking at the general fund itself and overall funding, because the two are ultimately, very much dependent on each other, and there's a fair amount of interplay in terms of how costs get allocated. And with that, I'll stop. Thank you.
Thank you, Harold. Actually, when you brought up the interplay with the general fund, I thought where you were going was the governor has a kind of self-imposed informal cap of 2% on state operation spending, so sort of total state-funded programs. The global cap is typically running 3 or 4%, and I think as I demonstrated, it's actually run quite a bit higher than that. And education also has been allowed to grow faster than 2%. And so the net effect of those two policies is that a larger and larger share of state spending is going to Medicaid and education. And by extension, that means a smaller and smaller share is going to every other thing that the state does, including the social supports that Rose was talking about.